Sorry for speaking English. I have 3 daughters and 2 of them will study Spanish. I'm very happy of this. I'm not able to. Thank you for inviting me. I've been member of the GRADE group from the beginning, 7 or 8 years ago. And we adopted GRADE in Italy 3 years ago. And I'm happy that you consider the possibility to adopt it. I will try to have a presentation as pragmatic and as interactive as possible, trying to keep it simple and hopefully clear. First, I would like to stress why GRADE was elaborated and why it was born, probably to overcome the defect of the many existing rating systems that were not giving us much help. And I will try to illustrate you how it works and offer you some examples. So, what are the problems with the existing guidelines rating systems? The problem starts from the fact that we, for many medical intervention, have low quality evidence, or to be more clear, do not know much or do not know enough about their real effectiveness. This is the big investment made by the BMJ is called the clinical evidence. There's been a huge effort trying to present in a short and clear way what do we know about the benefit and harms of most medical intervention. As you can see, 50%, and this is fairly stable over time. In the past 10 years, it has not changed much. 50% of the medical intervention that we use do not have adequate evidence supporting their effectiveness. It doesn't mean they do not work. It simply means that the evidence available is not sufficient to establish their benefit-risk profile. One consideration more is guidelines tend to be more and more big. They become bigger and bigger and probably becoming difficult to use. Every new update has 50% more recommendation, and only a minority of the recommendation has high quality evidence supporting them, and this can be or should be underscored and stressed and taken into account. The many authors that have commented about what we are doing are underscoring the fact that we need to prioritize our recommendation. We need less recommendation. We need to work more on implementation, as also Javier has stated in his introductory speech. Sometimes going back to primary data, that is to clinical trials and clinical studies, is the best way. And GRADE offers you some suggestions. A few factors more that also Javier stressed in his introductory talk. The composition of the guideline panel or guideline committee is very important, and sometimes the member you put in are the answers already to the many questions you can have. That is, you have to be balanced and wise in choosing your panel members, and do not treat recommendation as something unanimous. Unanimity in research doesn't exist. It exists interpretation, it exists discussion, it exists reasonable differences, but sometimes guidelines appear anonymous and unanimous, which is not probably the best approach. Sometimes they lack independent review. That is not your case. Javier has presented detailed and thorough referee and supervision from other experts. And finally, next session, in guidelines, there is a suboptimal management of conflict of interest. guidelines sometimes lack the rigor and clarity of making conflict of interest explicit that most papers published now are supposed to have. When we started, there were at least 3 or 4 systems. These three are probably 3 of the most well-known guidelines group working at the time, and these were how they rated an important recommendation on atrial fibrillation. Do we use or not warfarin for a patient having atrial fibrillation? And American Heart Association said the evidence was of medium or modest quality, but expressed a class 1 recommendation that is strong. American College of Chest Physicians from Canada said that the evidence was even lower, but the recommendation was in class 1. SIGN from Scotland, that have produced excellent guidelines in the last 10 years, said evidence was low, recommendation was C. So the confusion was with us. So GRADE tried to pick up the best from existing system and to make it as explicit as possible. So it's not a system to discover, let's say, universal truth or be sure of what we state, but simply to make the reader understand what the group has done. So it's not exactly just a rating system, but it offers a transparent and structured process for developing a synthesis of available evidence and a framework to the subsequent steps. That's also Professor Oliva in his nice sketch showed as the black box. From evidence to recommendation too often is a black box. We don't know how they decided for a strong or a weak. GRADE could help. It goes from framing a question, having one key relevant question at a time, developing a fairly restricted number of recommendations, defining the outcome of interest. This is a very important step that in most rating system is not there and is one of the foundations of GRADE. Then discussing about the quality of evidence, which is something now fairly well known, I would say fairly popular. The Cochrane has done a great deal of work on this. And finally, have an intermediate step in which we discuss also of values and preferences of the local context and finally reach the recommendation. I was very happy 4 years ago when WHO, after a strong critique in The Lancet made in 2006 by Andy Oxman and colleagues, said that many WHO recommendations and guidelines were not transparent and with a weak method supporting them. So in 2007, WHO adopted GRADE. As you know, WHO has a very wide range of guidelines produced that very often are not based on the evidence coming from randomized controlled trial, but from other types of knowledge. So it was very important that WHO accepted to present the evidence that is there in many recommendations that have to deal with policy, with health systems, and not just with clinical work. And as you can see, this is very similar to Javier's slide that he presented, the various steps to produce a guideline. The GRADE enters in the middle to define the quality of evidence and a couple of other steps that I now will go through, but the beginning and the end is as important as the rest. First of all, define the mandate, the objective of the panel, of the group. Who is giving the mandate to whom? This is very important also in relationship with the work of the specialty society that are very influential and very present in the field. And today the number of guidelines producers is extremely high. And finally, do not forget to make some effort for implementation and evaluation and updating. That is sometimes a time and when the energy are finished or vanished. When we produce a guideline, we are so tired, we are happy to put it on the table and then the work is done. Conflict of interest will be discussed in next session, and is quite important. The GRADE has published a lot. There is a good website you can go, and Pablo was in Canada for a year or two with the leading group of GRADE, and you can have all the material you need. So I try to keep it simple and illustrate you the 3 steps of GRADE. The first step is quality of evidence. I will only give you some details, not the analytical details, but it is something that, for example, now also the Cochrane has adopted, so you can have grade table from a Cochrane systematic review, at least the new ones. The second step is quite important and is part of the black box, which is what's the risk-benefit evaluation, what are patient values and preferences, resource use, and the feasibility. As you can see, GRADE is not endorsing formal economic analysis, but is suggesting that resource use, rather than cost, is a dimension to consider among the many others. Surely is there, so the collaboration also with the health economists has to be developed. And finally, the strong or weak recommendation, positive or negative. A rapid synthesis of why GRADE has introduced some new elements. First of all, the definition. The definition of quality of evidence is quite important, and as you can see, is how much we can be confident or sure that the estimate of effect we have is right. So we have to estimate the benefit and risk, typically of a drug or of a health technology. Are we sure that the estimate of benefit that we have is correct? And GRADE proposed 4 levels, and according to the degree of confidence or how actually sure we are of our estimates. But as I said, the first step of your group or the panel developers is to discuss about the outcomes. What are the outcomes? The expected benefit and harms. What do we want from an intervention? What do we want to know, or what patient need is the same. The outcomes are of benefits, and the outcomes are of potential harms or risks. This is an example from bed sores, which is something quite common for patients staying in hospital or in the elderly frail. What mortality usually is the most important outcomes. Very often we don't have data on this outcome. The healing is surely as important or slightly less. Quality of life is very important. This can be discussed, but probably each of us could say, I would rate quality of life 9 and mortality 7. Okay, but probably we don't have major discordance. And you actually ask the panel to vote. So at the end, you have the voting of your panel, and sometimes the specialists vote different from general practitioners, or sometimes doctors vote differently from non-doctors, which is something to be taken into account. And then when you find a discrepancy, you have to manage it. Manage it means discussing, making it open, taking into consideration the fact that there is variability. Then you have other outcomes, not very important, and in the end, the physiopathology that is good for research purposes, but not for patient care. But sometimes many studies end up in these, I would say, underbush vegetation that is around, and as you know, today one of the problems is how we handle the immense quantity of publication. Today in Medline there are more than 5,000 journals. So you offer your panel a sheet in which you give them the outcomes to be voted, and if you score 1 to 3 is useless, 4 to 6 is important, 7 to 9 is critical. Critical means that we methodologists try to apply our methods to the critical outcomes, and on those outcomes we define the quality of evidence. You have a list that can be discussed and changed. For benefits, these are the beneficial outcomes for postpartum hemorrhage, and these are the harms. When you give a drug, there are always also potential harms. So the change introduced by GRADE was the following. Before GRADE, most systems said RCTs are the best, and usually if you don't have an RCT, you cannot a randomized controlled trial, you cannot have high quality evidence. And it was too rough, too rude, and now we have more sophisticated reasoning, such as RCTs are surely, in terms of capacity to estimate an effect, are more valid. So they start with high quality, but they can have problem, and if they have problem, you downgrade their quality. Observational studies have problems because they have not two perfectly balanced groups, and but you can increase their quality in the presence of a large effect, a dose-response effect, and other factors that I will shortly show. So it offers a framework, this is the framework, to reason about available studies. So I would say the tricky bit from which Andy Oxman and Gordon Gaia started 10 years ago discussing the system was, if we start with randomized trials that have high quality evidence, they can have problem. This is a list of problems that all those who have read the clinical trials know, and you can reduce it. Observational studies are low quality evidence, especially for evaluating effectiveness. Probably they can do a little bit better for harms, and you can increase their quality if there are large effects, there are evidence of dose response and other potential factors. So this is the general frame that it started with. When you read a trial, especially a randomized trial, what the Cochrane definition of risk of bias, quite sophisticated and not easy for beginners, means is you can have problem in your trial when it is not blinded, when you have lost people in their follow-up, when the statistical analysis is not properly done. But more recently, we also have had alarming demonstration that trials are too often early stopped and are selectively reported, not according to their protocol. So now we have, I would say, a good checklist to evaluate clinical trials quality. And this is the first of the items, and probably not the more innovative one that GRADE has proposed. GRADE was very innovative, I would say, with these two new items to consider. One is inconsistency among studies, which suggests you or us that when you have many studies and they are in conflict or are heterogeneous or have heterogeneous results, there is a problem. And our confidence in the estimate is more in doubt, or vice versa, when all studies are consistent, we are much more happy, right? And this is a dimension that usually was not considered, and is probably one of the foundation today of systematic reviews that, for example, Cochrane undertakes in their work. And another factor very important is so-called directness of evidence. Is the evidence applicable, or for epidemiologists, generalizable to my patient, to my population, to my setting? And finally, more technical, if there are problems in terms of numbers, imprecise results means few events. But I would say these two are often very important, I would say especially for us, coming from Mediterranean countries, and most of the research comes from, or used to come from, North American, Canadian, that can have also a different approach to medicine, or sometimes they are even more aggressive in their doses and in their long-term treatments. This can be a factor to be considered in terms of directness of evidence.
Please, Nicola, 5 minutes.
So this is a summary that one of the Cochrane has produced for us. I spent, I think, a week of his life producing this slide. And is a summary of how this operation of summarizing evidence works. The second step that I will summarize in 2 slides is, if that is the evidence, what is the risk-benefit profile? And this first line is particularly important. Do the benefit outweigh harms or not? And this is a synthetic judgment. Cannot be operationalized. What is in the numerator is very different to denominator. Numerator benefits, denominator harms. So you have to express a judgment, considering also values and preferences, or your local context, and resource use, which is one element. This is how WHO has summarized these steps. This is one recommendation for HIV. They describe benefits and harms of early treatment, describe the feasibility and also the cost that seems feasible or sustainable, as suggested by the health economist, and whether it is feasible. Finally, all this big work is toward a direction, positive or negative, and it means how confident we are in saying do it, that we produce more good than harm. We weight the effects and we express a judgment. We end up with a strong recommendation when the desirable effect of the intervention clearly outweigh the harms, and we remain into the weak that probably you can do it, or probably we suggest you shouldn't do it. So you assemble your panel and you ask these people to formulate a recommendation either for or against, considering the quality of evidence, the balance of benefits and harms, and values and preferences, and also, finally and separately, resource use. I try toward the end, and just by adding that, is the first system that is perfectly flexible. You can have a strong recommendation based on low quality evidence, and you have to explain why, but this is what happened, for example, with oseltamivir and avian flu. WHO said for the treatment, although the quality of evidence is very low, the drug has to be used because we don't have any other treatment and the side effects are acceptable. Or another WHO guideline, we are all happier when we have high quality evidence and a strong recommendation, such as in the case of, for example, buprenorphine being inferior to methadone for pharmacological treatment of opioid dependence, but the dose was a strong recommendation with low quality evidence, and in the text it is explained why. So it is transparent. I jump over the two examples because of time, and I finish by saying that you have to keep in mind the overall process that also Javier has presented you quite well, and have a good mandate and try to govern well your groups. We should try to have smaller and more clearer guidelines with few recommendations, a reasonable number, 10, 20. A guideline ending up with 125 recommendations probably is worse than a textbook and not fitting its purpose. Use systematic review and do not perform meta-analysis by yourself. Ask those who can do it for you, such as the Cochrane. You have an excellent Cochrane here in Spain, Cochrane Center here in Spain. Great criteria can be good for quality of evidence, and explain in a short text what you have done to go from evidence to the recommendation. And if we are transparent, is surely one step forward. If I've been too technical, which is possible, let you smile for a second with this. This is Jonathan Lomas, who was an expert in guideline implementation. He just retired. He was from McMaster 2, where Pablo went for a while. So there are these people on the balloon and say, where am I? And this fisherman said, you're 30 meters high in a balloon. And he said, you must be a researcher. And the other one said, yes, how do you know? Because you told me something correct, totally useless. And he said, you must be a policymaker. Difficult to translate. Usually the policymaker is the general director. And he said, yes, how did you know? Because you don't know where you are, you don't know where you're going, and now you're also blaming me. Probably GRADE can help have some peace among us. Thank you.